Panel.
Deputy Philip Balash, member of the panel.
Deputy Lucy Stevenson, member of the panel.
And we also have an additional member today.
Yeah, I'm Deputy Catherine Curtis. I'm the Vice Chair of the Assisted Dying Panel.
So Deputy Curtis is joining us for some questions on assisted dying near the beginning of the hearing, and then she'll be leaving after those questions. Minister, welcome to the hearing. Could you introduce yourself and your officers, please?
Deputy Tom Binet, Health Minister.
Martin Carpenter, Health Chief Information Officer.
Ruth Johnson, Director of Health Policy.
Hazel Cunningham, Director of Finance for HCJ.
Peter Bradley, Director of Public Health, Medical Officer of Health.
Great, and I know that you have some additional officers, so as and when those additional officers come to the table, please ensure they introduce themselves before they answer any questions. Okay, thank you for making time to come to the hearing today, everybody. We have until 1:40 today, and as always, lots of questions to get through, so we will try to keep it at pace. Minister, your proposed budget is the highest ever set for your department at 381 million. Do you feel confident, if that amount is approved, that that would be adequate to ensure that health services can run smoothly, resolve issues around waiting times and provide the care that islanders need?
Am I entirely comfortable with it? No, I have to be honest, I'm not, but I'm very grateful for the fact that we're going forward into the budget debate with the numbers that we've got in place. I do think, and I don't mind saying it's the bare minimum, to the extent to which you can actually reduce all the waiting lists. I'm uncertain, and I'm grateful that you're sort of asking these questions at the beginning to set the context, because I think it's important that you know and that the public know that some of the headlines that have suggested that we're getting an extra £60 million simply aren't correct. And Hazel will go into some of the detail, but in principle, I think members of the panel will know that for a number of years, the budget that we've started with isn't the budget we've finished with, and the Assembly has voted to put money through to bring that deficit up. And I've referred to that all the way along as not an overspend, but an underfund. Now, as I think has been accepted, our deficit this year is lower than last year and lower than the year before. It's coming in at around a projected 12 million, but it's been accepted that we can't keep running that deficit just to provide the core funding that isn't dealing with the waiting list. So I'm very grateful that that now has been accepted into core funding. That's going to be made good, and the plan is that that extra 12 will be there next year. So what I'd referred to all the way through in the Assembly meetings as a baseline funding will roughly represent something that gives us an odds-on chance of finishing the year just about breaking even, so we don't have this constant talk about overspend. But if you take that assumption, add in the fact that this year we're going to get a funding formula that's not 2% above inflation but 3%, that'll give us an extra 3.6 million. We're looking for an extra 12, 4 for preventative health and 8 for digital. All of that relies, that ongoing number relies on £9 million worth of savings. And if we achieve those savings, we come out with an extra 15 million. But it's, as I say, that relies on saving £9 million. So in terms of real additional money, we're not talking of a great deal. The effect of long-term care, I think, is going to take away over £500,000 net of that additional money. And we are, to come in within the £12 million deficit, we're probably going to have to push about £1 million worth of spending into next year. If we wanted to absorb that and finish the year without pushing £1 million in the year after, that's £2 million next year that'll be taken up of that additional money. So if we're going to look after digital and preventative work and spend that money where it needs to be spent, and it will, I can guarantee you that will be ring fenced for that, we start the year not far off just having the money we need to come in with our deficit. So far from these figures of 60 million that have been claimed, it really isn't that figure. There's a key issue as well that gave rise to that, is we transferred ambulance and some other services in, which transfers £22 million. So it's got the appearance of being a much bigger number, but it includes an awful lot of different things that aren't explained in the press. And if the press are listening, I'm very happy to brief them separately so that the public have got a very, very clear view of what we've got and what the expectations are for us going forward against that sum. So you asked the question, how confident am I? we haven't just won a huge international lottery that's going to put everything straight. We'll be in a much, much better position than we are now, but we'll still be very tight. And I hope that provides a picture. I don't know if Hazel, if you wanted to add anything to that.
I'll just follow up and I might come
Sorry,
to you in a minute. Thank you for that detailed answer.
I'm grateful for you giving me the opportunity to explain that.
Thank you, Minister. So will the standard of care overall be maintained or increase or decrease?
I'm hoping, because I think we've got a good team together and a very clear vision, I'm hoping that things will continue to improve, and I think that can be achieved, to be fair.
Okay, thank you. And in terms of the underfunding, as you have described it, and you've mentioned several different figures, the additional money that you're asking for to address this, is that money just going to plug the gaps, as it were, or have you done a piece of work to understand kind of at a base level what each service needs within your department?
No, what I tried to explain, as I say, it's difficult to get your head around those numbers. It's all very well for me explaining them, but we spent some time going through to make sure we're sure of them. That's why I'm happy to do a separate briefing if you wanted to go through it at a later stage. But really, all we've got for standard funding is the money we need to deliver what we've been delivering next year without running a deficit. That's about where we are.
So it's plugging a current gap.
Well, it's basically accepting the additional 12 that we're getting is accepting that we can't keep starting the year without enough money and then filling the gap. What we're saying is accept that as baseline funding, and then we'll work very hard to try and finish the year without a deficit. Now, we will be getting the 4 and the 8, and that money over a 4 to 5 year period will prove progressively more useful to health and improving matters over the course of time. You bear in mind, we're going to cover digital, and I'm not going to steal everybody else's thunder. They know much more about this than I do. But where we are from a digital point of view is we start from a very low base. Mm-hmm. So over the 5 years, our objective is to have a first-class health service to move into a first-class hospital when the hospital opens. So we've got that period of time. We've got the money that we need to build up the digital provision to a really decent level. And the progressive application of £4 million per year for health prevention it'll be sort of an exponential gain as you go forward. You know, when you put that money in at the start, it's not going to make a huge difference in year 1, but by year 4, year 5, you'll really start to see benefits from both of those investments. So I hope that makes sense in terms of setting the context.
It does, thank you.
So just to pick up on your point about whether it's an overspend or an underfund, would you say that you will be able to stop referring to the health service as being underfunded as a result of this budget?
Yes, I'm hoping that we're going to change the narrative, and that's with some real effort we can come in with a balanced budget. But as I say, there are lots of other things going under the surface. There are quite long waiting lists in certain areas, and that this sort of money doesn't allow us to sort of savage those things and really bring them down. We can bring them down over the course of time, gently as we go. That's
the health service going to still be underfunded after this budget?
Well, I think you could, unless we had a massive windfall, you could argue that every health service around the world is always going to be slightly underfunded. It's a case of what can we tolerate as a society, what can we tolerate as an assembly, what's appropriate, bearing in mind that you can't give everybody everything they want all the time. So those are very, very delicate balances to strike, but that's the job that we've got. And I think, to be fair, if we can get this through, we'll be making some real progress.
So the Chair has pointed out and got from you the information that this is plugging a gap rather than a rebasing of health spending. What's the long-term plan for financing health?
This is more than plugging a gap. We live in a real world. We're already going some to be asking for the money that we're getting. We're very grateful for getting it. So I think this is a rebalancing, but it doesn't take us to, it's not a delivery to health paradise, if you like. It puts us in a good, strong position to make real progress. And in the real world, I think that's probably as much as we can ask for at this point in time.
The budget makes reference to this funding being pending or being before a work on sustainable health funding. So what is the long-term plan?
There's been much talk of this. I think there was an item from a clinician in the paper. Sir Philip made some comments recently at a party meeting, and all quite correct, that we need to be looking at where money is coming from. So our view is that work has to take place starting next year, but what the health service can't do is wait for that work to be done to introduce charges in 27 or another tax or whatever it might happen to be. And I'm not preempting anything. What we need to get the job done is some money. We need to put our hands on some money now. That's why we're putting our hands in the till and saying, let's get on and get the job right. I think it's difficult to say to people who want more money to fund their health service if there's no clear plan to put it straight. And you're not starting to show signs of delivering a slightly better service. I think we've got to have people's confidence that we're going in the right direction before we start looking anywhere from the public for extra money. I don't know if you'd agree. I just think that's a sensible course of
I think
action.
what I'm just trying to ascertain is there definitely going to be a piece of work done next year that will look at sustainable health funding? In other words, a long-term basis for funding healthcare.
Some of that has already started, yeah. And that as we go forward, that's going to be a major focus. It has to be, yeah.
And any idea of how long you would expect that to take?
Ruth, I'm not sure if I don't know if we've got a set timetable even, have we?
So we've started some work. We're working with our Treasury colleagues on modelling what we think our healthcare costs will be in future, taking account of the general cost of health inflation, so increased costs of drugs and treatments, but also the ageing population. But in addition to the ageing population, changes in disease prevalence, because even people of middle age and younger people more of them are living with more disease.
The time scales on that work?
So we're actively doing the modelling work at the moment. We are hoping that within the first few months of next year, that modelling work will enable us to understand what the future costs of health and care will be as a percentage increase on current budgets. We will then need to, once we've got that figure, we will then need to start exploring what the options are for plugging the size of that gap.
So
and
will that be ready then for whoever the next health minister is?
So that's
the next budget?
so that's absolutely the plan, that we understand the scale and the size of the problem before the elections, in order that the incoming Council of Ministers have got 4 years to address the issue of how we fund our health system moving forward. We don't know what that solution is going to be at the moment, and one of the reasons we don't know what that solution is going to be is that we do not have a forecast for future expenditure that everyone is confident with at this point in time.
Okay.
So the health budget since 2022 has gone up £150 million, 149, some of which I grant, moving in ambulance services and inflation accounts for some of that, but not by any means all of it. You are confident with this 15.6 million extra a year that you can put a cap on that, and we will now just see inflation plus 3% going forward?
Well, we are looking at that 3% formula to decide whether that 3% formula is appropriate, and I'd probably best that Hazel
Well, I
gives
think,
a bit more information.
thank you. So following on from what Ruth has said, so that is the work that the working group are looking at the moment in terms of modelling. So what is appropriate? So some initial work, indicative work was done that indicates that figure should be higher, but it needs fully testing, and that is the work that both health colleagues and Treasury colleagues are doing together, so that we can make sure that we're sort of kicking the tyres and everybody's really confident about how we've built that model, the factors that have been included are relevant, and that we've got the data sitting behind it, and that's what we'll bring forward, as Ruth has mentioned, to the new Council of Ministers next year.
When does that work start?
So it's really weeks, if you know. So what we've been doing is continuing the work that was started as part of this budget proposal preparation. So going back to your other question, so we have got data sitting behind the 12 million deficit that we're forecasting at the moment, and that is supporting the additional investment that is within the proposal. So we've got broad areas identified within there which are creating those pressures, where it is difficult to control expenditure. So as you've probably heard and read in other reports that we've done, so for example, tertiary care, so referrals over to the UK is a significant pressure. Those packages of care are quite often hard to predict. And we are subject to inflation increases within NHS trusts. Mental health packages, your single packages can be very expensive, complex care. So there are those areas that are difficult for us to predict and manage, as well as other pieces of work that we've been doing. So there are a number of key areas. The Minister mentioned also the implications of long-term care benefit increases, which impact on the health budget, where we top up packages of care. So there have been significant costs there. So there are a range, and that will feed into the ongoing work that we'll bring forward next year.
This is being done alongside a health strategy, because obviously some of the things you could do, you might go and put more care in the community, which might reduce costs. You know, how does this interact with a strategy for how we're going to treat people into the future?
I'm always interested when people refer to strategy. I mean, I think we've got a strategy on the move at the moment. The implementation of a partnership board, which is going to give us the means by which a strategy, if you like, an operational strategy can be developed. The sorting out of the core funding, they're looking for additional funding to get digital underway and to get health prevention underway. Unless you've got these cornerstones and foundations down in your health service, said, why don't we have a strategy? Well, what would we base a strategy on? If nothing's digitally connected, you're not doing any health prevention work, you haven't got the right funding, and you haven't got the means to actually do anything. It's like saying you're going to go on a journey in a car, and you're planning the journey and booking the hotels, you haven't got a car. So what we're trying to do is, our strategy at the moment is to get the ship in shape, as it were, so that we can actually then say, right, where do we want to fine tune the delivery of this? And I think the partnership board is going to be quite fundamental in terms of not just the board itself, but the subgroups that we're going to develop for each speciality that bring people into the room from the whole of the health journey for each section to actually define that. So that's work to come, but as I say, let's get the foundations down before we do that.
Thank you, Minister. And a general question which has arisen this week after some reporting on safe working hours, and in the context of the budget, could you give us some detail as to whether there have been any changes made to how your department employs staff as a result of attempting to make savings? For example, a decrease in bank staff, was that an attempt to make savings?
No, we're trying to get more permanent employees in place because they're cheaper. The whole system is more reliable. So now that's a different a different exercise. And I'm just looking around and wondering why we haven't brought Stephen James, our HR director, with me, because he's been doing the work on this. And to be honest with you, with the amount of other stuff that's been going on, I know that's been in the news, and I have to say that I haven't been able to put any particular focus on that just through simple lack of time. But I know that in Stephen we've got a very reliable HR boss, and I think he's doing a good job. So I'm comfortable that whatever problems have arisen, he'll get to grips with.
Okay, is that something that you could look into and get back to us? Given
It's on my agenda. I'm hoping to have that discussion with him tomorrow. We do meet on a Thursday afternoon. Okay. So yeah, it's on the agenda. Yeah, if you can.
In terms of, so you'll be aware we have a financial recovery plan, which has numerous streams of work. So there are a number of streams that look at our pay-related costs, and how we make best use of our resources. So as the Minister has said, there's been a really big push on permanent recruitment, so moving away from the use of agency and using bank where it's appropriate and overtime. So we've made really good progress actually. So in terms of the current forecast and our use of substantive staff, overtime and agency, we've made really good progress in balancing that budget using that mix of substantive and temporary staff where we need to. Particularly in nurse recruitment, we've made great strides forward in nursing recruitment, and we've still got a pipeline of new appointees coming through until the end of the year, so we'd expect the vacancies to be falling further in nursing. There's still some more work to do around use of locum doctors, and that's part of the work that we've been doing as well, in terms of how can we effectively use, whether it's locums, whether it's bank, how can we do that in the most cost-effective way? So there has been a significant focus this year across the department in those areas.
And is the well-being and the safety of the staff and the patients as important in the decision-making as the saving money?
Yes, so any consideration around savings, there would be a quality impact assessment that would be conducted as part of that if it was affecting staffing, but there are ratios of staff to patients, for example, that are obviously followed.
Thank you. And Minister, I think you said that it's more important, which is good to hear. So will you be taking on board those recommendations from the Safe Working Hours Guardian?
Indeed, as I say, it's up for discussion tomorrow afternoon, and we'll be going through that very, very thoroughly.
Sure. Okay, thank you. We may come back to some of these areas as we touch on the different sections of the budget, but I would like to go to Deputy Curtis, who is my Vice Chair on the Assisted Dying panel, and she has some questions around assisted dying.
Okay, thank you. Minister, within the growth allocations table, it shows that the estimated funds for assisted dying go from 525,000 in 2026, 727,000 in 2027, 688,000 in 28, and 718,000 in 29. Could you please outline how these funds were forecast and the reason they go up and down over the span of the budget?
I'm going to hand straight over to Ruth, who's got the answer to all of that.
Yes, so as we've been very clear about the assisted dying budget, so the budget that's in the government budget is exactly the same as the budget that's set out in the report and proposition for assisted dying. We are very clear that at this point in time, it can only ever be an indicative budget based on best possible predictions that we've been able to make, because we quite simply don't know the numbers of people who will request an assisted death, the numbers of people who have an assisted death, and we also don't know about the complexity of those cases and therefore the numbers of hours staff each case will take. So we've done some projections around that. But the way that the budget works is, as you know, we are assuming that the States Assembly agree the law in January next year. We are anticipating an 18-month implementation phase. So the budget for the 18-month implementation phase is the 2026 and half of the 2027 figures. That is the money that's required to do things like bring in a project manager to support us to stand up what is a novel service. It is to do things like develop the training package that we need. So we will have to develop a bespoke training package for assisted dying. It's the costs associated with that. It's the costs associated with training the staff. It's an allowance for recruiting staff, for the development of all the guidance. So in the 2026 and half of 2027 budget, what you've got is you've got the costs associated with standing up the service. And then in the 2027 budget, we are working on the assumption and the prediction that people will start to request assisted deaths partway through 2027. So in 2027, you've still got some implementation costs, but you're starting to see coming through the costs of the staffing costs associated with people making requests and people having assessments and people accessing counselling support for assisted dying. We then move on to 28 and 29 in the budget, and the costs in 28 and 29 are almost all related to the provision of the service. There is a core amount of cost that's related to audit, oversight and governance of the service.
What is that figure for the core costs?
I would have to, sorry, I can't, it's a complicated budget. I would have to send that to you separately. And then you've got people coming through for those assessments. And what we are anticipating will happen, because this is what's happened to assisted dying services in other jurisdictions, is that the numbers of people requesting an assisted dying in kind of like the first 12 months is relatively small, but over a period of time, the numbers of people requesting assisted deaths increases as more people become aware of the availability of an assisted dying service. So the reason why you see that increase from 28 to 29 is we are working on the principle that we will have more people requesting assisted deaths and therefore more staffing costs.
My next question was going to be asking you about the costs in 2026, but you've mentioned about training, bringing in a project manager and so on. So you're saying that 26 and 27 includes a lot of setting up
Yes,
course.
it does. Yes.
Could I just ask, when you mentioned about training, has there been much research done on how much training will be available in the islands?
In the
Here, or
in-
will people have to be sent
Oh,
away
so
for training?
the way that we are envisaging that the training will be done is that we will develop a training package, a bespoke training package that is delivered on island for assisted dying practitioners. You may recall that in order to be an assisted dying practitioner, to be registered as one, you have to go through mandatory training. So what we're talking about is the mandatory training package for the Jersey Assisted Dying Service, which will be different to any assisted dying training delivered in other jurisdictions, because it will need to reflect the law and the requirements of the law. So it will be on-island training, and we will very shortly, within about the next 2 weeks, be lodging an addendum to the Assisted Dying Report and Proposition, which provides a lot more background about how the training will work, and it will be a mixture of online modules, but also face-to-face training, including kind of scenario training, etc.
Okay, thanks. That's okay.
One can understand that with a new service, it's very difficult actually to understand what funding is going to be required. But some funding has been allocated, I understand, or the panel understands, from the Central Reserve. And I wondered if you might tell the panel how much funding assisted dying has been allocated from the Central Reserve Fund.
I'm afraid that is I can talk to you about the assisted dying budget, but I do not know the detail of how the Treasury have made decisions about the allocation through from different parts of government money.
Perhaps the Minister can answer.
To be honest, I can't cast any light. That would be a question for the Treasury Minister, I'm afraid.
It's not allocated to
Would you
issues.
like to answer?
Sorry, I was just so in the budget proposal, it states that the assisted dying money is being held centrally. So at the moment, it's not sitting in the health allocation. Once it's agreed and once the work continues, then we would draw that down from the central reserve. So it's being held centrally by Treasury at the moment.
Okay. You happy with that? Okay. Just one small follow-up question related to something that you said about the training. And we noticed in the legislation, when we've been scrutinising it, that the training, I think it was in the appendix to the report, the training would be renewed every 3 years.
Yes.
How does that compare to other jurisdictions? Is that shorter or longer or standard?
Lots of other jurisdictions that provide for assisted dying do not have any requirements relating to their training established within their legislation. So our law is different on that extent. We have, in terms of the renewal of training, we've looked at what they do in some of the Australian states, where they often have mandatory training, but it's not necessarily enshrined in law. And the periods of renewal tend to be between about 3 and 5 years, and we've gone for the shorter time frame.
Thank you, that's helpful. Any more questions on assisted dying? No. Okay. Yes, thank you so much for joining us, Deputy Curtis. We're going to move on to do you want to do this?
Isn't it?
What's this one?
Digital. I think wasn't. Did you not want digital dealt with?
No, it was the health deficit.
Yeah.
Oh, I see.
The funding
Sorry.
we wanted to provide the context.
Okay.
Are you happy to go to?
The new hospital.
Yes, so we have some questions. I'll thank you for your answers.
Well, actually, Jess isn't here, so we might as well
Oh, of
wait.
course.
We might as well wait.
Right.
She's coming as soon as she could.
Yeah. Okay. So.
Okay, Deputy Stevenson, are you happy to begin your section on the digital health system digital foundation? Sorry.
Thank you. And the Minister, you've already touched on it and said that the cost for digital health stated in the budget is £8 million year on year. Is this figure adequate, and how certain are you that the plan can be delivered within this funding allocation?
A number of things that are sort of reasonably obvious. It's a lot more than we've got at the moment. I have to be honest, in an ideal world, I think we could have done with a little bit more. But in terms of what can and can't be delivered, it's much easier if I hand straight over to Martin, who's got a very, very comprehensive view of that.
The Minister asked us to develop a plan which would enable better delivery of healthcare through the introduction of digital technologies. So that's both the technology and more integrated data. We produced a plan that we then circulated and went to Treasury colleagues, which was around about just over £70 million over 5 years, and it consisted of 5 elements within that plan. So there's an element which is to do with implementing something called e-referrals, which allows the electronic transmission of patient data, referral information from GP practices to acute practices and off-island as well, and for that information to come back as discharge information. So there's a really good flow of information around the system. Currently, that happens in a very ad hoc and sporadic manner. Also allows us to put in place e-referrals, which gives better patient choice. E-prescribing, which gives better patient choice in terms of how medication is supplied across the island. The second element is to create a single patient record based upon technologies which are used in very well developed digital economies such as Estonia, Slovakia. Technology is also used extensively in the UK, in London. Third element was to create a digital storage for documents. Jess will tell you that in the new hospital facilities programme, there is no room for any analogue documents, so the old folders that contain patient notes. So we're going to have to digitise that. Fourth element was what we call Get Smart, where we're able to take information from various remote monitoring devices that allows us to develop virtual wards and remote monitoring. So allows us to do more community care and provide preventative services in terms of if we can see that somebody is becoming unwell, have treatment in the community rather than allowing people to become more unwell and then take them into hospital. And then the fifth element was for an advanced analytics platform. So what we've done is we've said we can afford to deliver the first 2 elements of that plan. And because colleagues in Digital Jersey have done an award to family nursing, there is an element within step 4, which is the Get Smart platform, that we're also able to make progress on. So the remaining budget of 30-odd million would pay for those other elements that we're unable to deliver as part of the initial programme. But I'm confident that within that we are able to deliver our commitments.
So although the first 2 are only covered in that 8 million a year, you're saying other areas are going to cover the other 3?
So we've Digital Jersey have made an award that allows us to get on with the Get Smart platform, but the document management system and the advanced analytics platform are currently excluded from our plans.
Can I just ask for clarification? Can you just give us the heads of each of those sections? So e-referrals was the first one.
E-referrals and e-prescribing, we also need to get hold of NHS numbers. So this isn't
so is that the third thing?
So that's as part of step 1.
Yeah, so the third thing.
Second one is a single patient record.
So hang on, so e-referrals and e-prescribing with NHS numbers, that's your first thing, right?
Yeah. Number 2, single patient record.
Yeah.
Number 3 is the document management system.
Yeah.
Number 4 is the Get Smart platform.
Yeah.
And then number 5 is the advanced analytics platform.
Thank you.
So this has embraced primary care as well.
It does, yeah. So we're taking a whole system approach. So very much how as a system are we going to work and improve flow. I think what I recognise is we're a small community, and what we can't afford to do is have multiple platforms doing the same thing, irrespective of whether they exist in private provision of healthcare or public provision of healthcare. We need to make or figure out commercial arrangements where we can have single platforms that are for use across the community to make things really effective.
I think it's just worth saying from a political point of view that Martin's remit is very clearly not just to deal with HCJ, but to be part of the overarching department of the board and link up every element of healthcare.
Okay, so would that include like health visitors, for example?
Whichever tertiary care connections to charitable provision, it's the job is to link up the whole. As a that's part of the beauty of having an overarching department for the board that deals with health as a complete provision rather than this sectionalised approach that we've had today. The other thing, I hope you don't mind me barging in and making another political statement. I think, to be honest, in year one, it would be difficult to have spent more than 8. I think that's probably safe to say. We're comfortable we can spend at 8. Probably couldn't have spent a great deal more because we hit the ground running in January. But I think, I don't know what's going to happen from a ministerial point of view when we come to the next assembly. But whoever sits there, I think I would urge them strongly to perhaps look at trying to build up the funds for digital, because I think proper digital connectivity and having all the bells and whistles and introducing AI and all the rest of it is going to be what's fundamental to make us more efficient. So I think there will be an argument for increasing that 8 by a few more million over the course of time, because it's only through being efficient that we can bring our costs down.
I am going to come back to that point in 1 minute and ask for a follow-up on that, if that's okay. But just before we move away from it, the Get Smart programme with family nursing and home care that they're now, will you still be linking with them to ensure that it's all working together?
Yeah, I'm working very closely with FNHC and also Digital Jersey in terms of making sure that this is an integrated island approach. And in fact, when the technology was chosen, Digital Jersey asked me to have a scan through and make sure that I was satisfied that the appropriate technology was chosen. I just wanted to add that this is not only about efficiency, this is about patient safety. We in the hospital, we're recording an average of about 80 patient safety incidents a month as a result of fragmented data. And when I've talked to colleagues in primary care, they say, yeah, but you're not recording any incidents in primary care as a result of that fragmented data, nor are you when you're talking about domiciliary care and secondary care provision. And having that integrated view of Islanders' health, I think, is going to be instrumental in reducing those number of incidents.
When you say it's 80 incidents, can you give us an example of what's an incident?
So we have had incidents whereby we've had do not resuscitate on a patient record, but because people are not aware of the patient record, people have been resuscitated. So that's an extreme example. We've had other examples where referrals have come in and people haven't known exactly about the medical history. Issues to do with allergies and reactions to drugs and medication are not being flowed through the system. So they all create issues in terms of safety. And then in terms of efficiency, what I've been told by some of the big consultancies is we can expect to see a 15 to 20% improvement in the efficiency of people who are working across system level in the provision of health and care. So, that's definitely not saying we can reduce our workforce by 15 to 20%, but we can certainly improve the quality of care that we're giving to islanders.
Thank you, which brings me nicely back to the follow-up question I was going to ask you, Minister, about the projected cash releasing benefits of this type of investment. Talked about a 15% efficiency saving there. Have you've done that work to see what?
I don't think we need to. I don't think we can really look at this from a cash releasing benefit point of view. I think I made the mistake of not mentioning patient care being central to every single thing we do. And when I talk about efficiency, it's efficiency that's going to mean that the care we give people is more joined up, and that when people enter the health service, they move more quickly through the system, and they don't fall through it, because a number of issues that I see, a number of complaints that end up in my inbox, and myself and the system ministers have an inbox full of people complaining about things, and very often rightfully so. Quite often, in fact, more often than I care to think about, it's because people have fallen through the system between the various departments, or drifted onto a too difficult list. It doesn't, and you haven't got the systems to pick these up and keep people's health journey flowing sequentially through the system. So what we're trying to do is to shorten that journey, to make sure people get in, get properly seen, and everything that happens to them gets carried through to the next stage. So when I talk about efficiency, we're talking about patient. Everything that we're doing in all of this stuff is centred around patient care. And you make a good point.
So just to follow up, within our business plan, which is quite a lengthy document, we do have listed quite a lot of benefits that we expect to accrue from implementing the digital plan, both in terms of efficiency and in terms of patient safety. In my mind, digital is an answer to part of the issue that we face and we were talking about earlier, in that gap between demand for health services and the amount of activity that's going to happen as population gets older. There's more comorbidity, there's more activity, and the ability to service that effectively. So it's about bridging that gap as opposed to delivering core cashable savings.
Yeah. And another thing to sort of point out is it does link in with health prevention, and you can actually gather data about the effects of what you're doing, the effect of your investment, and seeing that coming through. So everything is interwoven. Sorry.
The single patient record, I mean, we've been working on an electronic patient record system since 2020. There's a CNAG report, on that. Are those two things the same? I mean,
they are different.
So how are we going to make sure that this thing which took ages to deliver isn't going to fall? How are we going to make sure the single patient record doesn't fall into the same category?
So the electronic patient record that I think you're referring to is the one that went into the hospital to replace track care, which was seen as a risk. That system is designed for use in a hospital rather than as a whole system approach.
So has it been thrown out?
And it's not being, no, it's augmented. So what we're doing is we're taking all of the core systems. So we have the hospital system, we have the community-based systems, which is around EMIS, so the system that's used by GPs, family nursing and the prison service, and also the system that we're putting in for adult social care and mental health. And all of that information flows into a central repository so that we get a complete 360-degree view of what's happening to those individuals. There's a lot of work which is happening in the background about data sharing and data controllership, as you can imagine. People having access to that data and appropriate and secure access to that data needs to be really well controlled. But that's the architecture. And as we accredit new providers of data, we'll be able to bring data into that process as well. So whether it's from optometry, dentists, hospice, so a much wider variety of data than exists just within government.
Is this all health service centric in the sense that it's designed to help medical professionals access information more easily across the board? Or is it also concerned with the patient So, I mean, can I look at my phone and see whether my blood test results are there?
Yeah, that's a really good point. And yes, the intention is to allow that. And in fact, we're quite a way down the track at the moment in the hospital by implementing a system that will allow people initially to have a look at blood tests, and then over a period of time, and when I say over a period of time, less than a year, we'll be able to offer online appointments for people into hospital by using their mobile devices. We do have a little bit of a way to go in terms of working with colleagues in primary care to allow people to access records. And I believe that some practices already do it, but the intention is that the intention is to allow people to access their own medical records, because I think that's another important step in people owning their own health, as opposed to it being the doctor's problem, actually understanding what's going on with you, with yourself, and owning your own health outcomes. I think it's going to also lend itself to improved and healthy islanders.
That's a good question. I wanted to follow up on that in terms of the data sharing. If a patient doesn't want their data, for example, from a hospital specialist to be shared with a health visitor or a GP, will it be customizable in terms of permissions?
Up to a certain point. I think it's really important to understand that as a health and care professional, to give the best possible intervention, you need as much information as possible. So it's certainly within those organisations that are in receipt of public money, we would expect by default that health information is shared. For those organisations that islanders are contracting with on a private basis, then I can completely understand if they would prefer not to have their information shared. And that's custom and practice. So if you look across the water in England, Scotland and Wales, that happens by default, that health information is shared amongst providers.
Could that consideration of that be built into this work? Because certainly from the casework that I have with parishioners, it's something that comes up quite a lot, I think, given the small nature of our island, a hesitancy around people having such, medical data is the most personal, isn't it? So if that could be baked into this project and that understanding of the Jersey context, I think that would be... It's
occupied quite a lot of our discussion.
Yes, it has, absolutely.
We're trying to find the best way to make sure that people get the best care, and some of that is just about information to them, because if somebody decides they're going to stop at various points, it's likely to compromise the care that they receive.
Will the information be sold at all?
No.
Will it be traded?
No.
Even anonymised?
So the technology that we're implementing would allow that if it was a decision by the States Assembly to allow that to happen. But there is no plan. I've got no plan at all to sell that data.
And will it be available to other departments and to Statistics Jersey? So will Public Health be able to analyse data from it?
Absolutely, and I've been working very closely with Public Health colleagues to make sure that the digital health plan meets public health needs. I believe, we both believe actually, that it's absolutely crucial that we have better and more consistent and reliable data to drive the public health agenda.
Just to wrap up, I think on this section, then if we talk about kind of standards of systems or whatever, what's the kind of gold standard of digital health, and how close and far away will Jersey be in achieving this? And then just as a follow-up to that, the 2 out of the 5 that were missing, what's the future plan for them?
Okay. So when I set off on this journey earlier this year, I asked an organisation called HIMSS to come in and do a maturity assessment on how digitally mature Jersey is as a system. And they measure they measure between 0 and 7. So the hospital, because of the investment that we've done in the electronic patient record, is currently sitting at a 3 and a bit, and we're hoping to get that to about 5 over the course of the next 6 months. As a system, we're at level 0. And out of the 26 jurisdictions where they have made that assessment, we are number 26. My ambition is for us to move rapidly up that chain. I don't believe that us hitting level 7 is necessarily something that we should absolutely aim for. I think, though, aiming for the high levels, at high 5s, kind of 6 level is probably where we need to be. And just to give you an indication, Middle East countries, which have got lots and lots of money that they're throwing at digital health, are achieving level 7, but they operate in a different world. The second part of your question, what are we doing about the remaining elements? I've been working with Treasury colleagues, and they've said that we should resubmit in 2026 for additional funding to fund those elements that we haven't been able to get over the line in 25.
And if that was to happen and funding is in place for them, those 5 elements happen, would you confident you'd be achieving the ambition of 5 to 6?
I think we'd very confidently be hitting level 6.
Thank you very much.
Okay.
Which are the jurisdictions in 1, 2 and 3?
Interestingly, our ex-colleague at Hampshire and Isle of Wight NHS Integrated Care Board are currently at level 2.5, and that was back in 2023, I think it was. So they've made improvements since then.
To say that our current position, I think you would agree, is pretty sobering, and the ambition is for the opening of the new hospital to be as near as we can to level 6.
Yeah.
That will require a little bit more money, but I hope if people watch the progress of this, that they'll see that it's well justified.
Thank you. I would like to have some further breakdown on that 8 million and what's going to those different, but probably not in this hearing. I think we'll ask for that in writing as a follow-up.
And just, sorry, Minister, just to pick up, so that bit of extra money, actually, if I did my maths right, when I think you said... Go on, you just tell me, sorry, I don't get my maths wrong, you tell me.
70 million is what we asked for over 5 years, and we've got 40 if you extrapolate this over.
So it's a 30 million.
Yeah, it's a 30 million.
Okay.
Yeah.
Thank you.
Okay, I think we've finished on the digital health. Thank you for the answers. We will soon come to the questions on the new hospital facilities, but we will go first to the Prevention First programme, then we'll go back to those questions on the hospital and give you a chance to get settled. Okay, so there is 4 million per year in the draft budget set aside for preventative health year on year. Minister, could you briefly describe how you reached that figure of 4 million, and is it considered adequate for everything that you want to achieve?
Right, we started from a different place. As you probably know the background to this, we started with a higher number, and as with all politics, you start with what you want and you end up with what you can get, and over the course of the summer and various negotiations we came to a figure of 4. I'll just state while I can, I'm grateful to other ministers for sitting on the sidelines and watching health move along with some fairly big increases while they've been restricted, so I'm very grateful for that. And I think after explaining everything through, I think people sort of understood, but it's been a bit of a difficult journey. So what we've got is we've got in the budget, and I know it's not passed yet, but we've got 4 there now. We would have liked, I think, what was our target was, yes, we had a very ambitious target. But
Could you just detail how much was the original bid for this?
well, initial this all started a long way back with Project Breakwater. It's gone in different directions, and we've gone. I think it was 12 we were looking for. We're looking at 4. The truth is, as with digital, we'd have had trouble in year 1 to spend that sort of sum of money. Once again, with the 4, we know we can spend it, and I think there's an argument for trying to up that sum of money as we go forward. But as I say, these are early days, and the 4. What we did is we had various sessions where we evaluated what we thought. If the sums were going to reduce, we had a priority list, and what we've ended up here with the 4 million we've got is what we collectively thought was the best way to use that money to prioritise.
Sure,
So
thank you.
it's
So
been a process, and that's where we've ended up.
Sure. So the bid was for 12. 4 is what you're asking for in the budget. And could you or colleagues outline briefly what kind of interventions will be covered under that 4 million if it's approved?
Yeah, I can start. So just the ambition here was particularly underlined by the modelling that we did a bit earlier when the Director of Public Health report showed that people on average have about 20 years of ill health. And that would require in time, in the next couple of decades, us increasing our bed days in hospital by about 30%. So that's the situation that we were trying to address, as well as obviously giving individuals better health. So there are 3 main themes to our proposal. One is about identifying those people at highest risk of developing these chronic conditions. And we can do that in a number of ways. We can offer a health check, or we can, if people have consented, working with the Health Chief Information Officer, Martin Carpenter, look at people's data. So if they are seen to have raised blood pressure or raised cholesterol or other factors, we're able to offer them timely advice and support. The second theme is really about using evidence-based programs which are specific to either preventing or helping people manage a condition at a very early stage. So an example of that would be diabetes prevention. So we know that diabetes can be prevented 80% of the time if it is if people are given the right support. So that would be potentially a mixture of medical advice, medicines, but also lifestyle advice. And then the other element is about earlier diagnosis. So typically this would be around areas like cancer screening. So we know that there are a number of cancer screening programs that have either recently been introduced in the UK or are coming on stream. So things like lung cancer screening, extending the bowel cancer screening. And so that is where the bulk of our money would go. In actual fact, there are about 10 or 12 elements, which should be a long list to give you at the moment, but we can certainly provide that after the meeting.
Thank you. And I've just realised we do need to introduce your colleague.
Sorry.
Yes, hi. So I'm Daniela Raffio, Deputy Director for Public Health Commissioning.
Thank you very much for joining us at the table. And my follow-up to that would be, so with the 4 million, those programmes that you've outlined, does that fall mostly under primary, tertiary or secondary prevention?
It's primary and secondary.
Okay.
Yeah.
Okay. So there is some primary prevention.
There is some
that.
primary
Okay.
prevention in there, particularly I think some of the lifestyle interventions. I think possibly in your question is how much we would relate this to other government activities. So we know that some of the drivers for poorer health are related to factors outside of health, service provision certainly, so housing, income, those sort of issues. I think we would have a long-term ambition to look right across government and see if we could develop services that were really focused on an individual, because it may be that any one point of time an individual has a particular concern, for example, about their housing, and we should in time be able to provide that advice and then move on to the health issues later. That would certainly be a personal ambition that we could do that.
Okay, thank you. And in terms of public health and health prevention in other jurisdictions. How does Jersey compare, and will this additional money bring us closer to what might be the ideal standard?
So I think it's slightly similar to the picture described for digital health. I think we're coming from a fairly low base. Although at times gold standard prevention is offered to individuals, I think our prevention offer currently is very fragmented. So this really is our opportunity to bring us much closer to other comparable jurisdictions. I think the thing that would make this a smarter way to work is certainly the joint working that we will be doing around digital health. So if we're able to identify those people most in need, that is going to take us a much closer to what we might wish to see. So it feels like a very positive trajectory, but I fully acknowledge we have quite a way to go.
Sure, and this joint working, if your digital project proceeds as you wish, Minister, which year would the data from this digital project, if it's fully realised, what year would that be able to be then utilised for health prevention?
Our ambition is that we get level 1 in place by the end of 2026, which is the NHS numbers e-referrals, with electronic prescribing to come in 2027. And during 2027, we'll implement the single patient record. We're going to be working on these things in parallel. It's more complicated in terms of the single patient record, and initially that will consist of information coming out of the hospital and information coming out of GP practices, and information coming out of our adult and social care practice. So that's going to be the core information set which we can then share.
But when could that be
And that would then be used, and then that can be used by public health colleagues at that point.
Which point, sorry?
In 2027.
27?
Yeah.
Okay.
Is it not safe to say, Martin, that we get progressively better and more constructive as you go through? It's rather than having a single point at which it will become useful, I think it just becomes more and more useful the more developed. The more developed that both sides become, the more integrated it will become.
Sure.
I just wanted to answer in respect of your previous question about spend on preventative healthcare in Jersey compared to other places. Within the main business case, it outlines what we spend compared to other places, and it's currently 2% of our CHE as a total. The UK spend 4%.
2% of what, sorry?
It's called the CHE, the combined health expenditure. Yes, thank you.
Clarifying that.
Yes, compared to 4% in the UK, and Canada's spending up at almost 6%. So it just gives us a kind of idea of where we're.
So 4% in the UK and Canada 6%.
Almost 6%, yeah.
That's interesting. And would you say Canada, for example, is that the gold standard in terms of health prevention, public health, or is there another jurisdiction that we should be aiming to?
I think we need to look at best practice across the world. So Canada would definitely be good. Some of the other English-speaking countries have very good records with prevention. But I think we need to develop our own model for Jersey, partly because of the nature of our communities and partly because we do have this opportunity working very closely with digital. And I think we will look across internationally at best practice, and we'll do that on a case-by-case basis.
Sure, okay, thank you. Yes, go on.
So just leading on from that, this is quite a constable sort of question, but have you liaised or spoken with the parishes about a preventative health strategy? Because we deliver a huge amount in the parishes, from babies, we have baby yoga right up until 90 plus classes, for sitting Pilates or whatever it is. And I just think because
you've caught me out here.
Yeah, parish halls are they're easily accessible. We have parking. It's right at the heart of the community, and we have And in St Miles as well, we have health and nutrition classes and all sorts of things like that.
Very good point. And you can rest assured in the next week somebody's going to be in touch with you to make your committee
Thank
and
you.
Conitable and see what
Yeah.
we can actually do.
I just think we could
that.
deliver a
It's
huge
a very
amount
good-
in the
very good
community.
point indeed. Yeah.
Yeah, thank you.
Yeah, great. Thank you for the question. Okay, so I'm just looking at my questions because some of them have been answered. In terms of some of the, say, for primary prevention, what might it look like to an average person if this 4 million is granted? And can you just give some examples of primary prevention? What that might actually look or feel like to an average Jersey person?
Slightly repeating myself, so excuse me, but certainly we would see people invited to cancer screening at the appropriate times. That offer would expand. Sometimes that would be an expansion of the age group that's offered, or sometimes a new programme. We are planning on having a health check around the age of 40, because we think that that's the age where people begin to think about their long-term health. Should anybody find that they have a number of risk factors, such as raised blood pressure or raised cholesterol, they then would be offered more support, and that would be comprehensive support. So people would get their advice as a package. So it may be that they're offered some medication, but they'd be offered some lifestyle advice at the same time. That's the sort of thing that we would expect, and I would hope that that will change the culture as well. So increasingly in healthcare, when people are visiting for a medical reason, that they would also be offered these prevention measures and would be able to make sure that anybody at risk was offered the support that they needed to keep themselves well.
Okay, thank you. So screening and health checks, so more of those. And that feels, I mean, obviously, I may be wrong here, that feels more like secondary prevention from the definition I'm looking at. And what I want to understand is, in terms of primary prevention, actually stopping things from occurring at all, possibly interventions that target children and education, is there anything covered in this 4 million that would address that at that level?
So we had all of that in the original £12 million business case.
Could you give some detail on some of the things, Minister, that you would have liked to ask, that you would have liked to have
I
a funding
believe
for?
that was all presented to you yesterday by Daniela, but really that was more about lifestyle interventions at an early stage, tackling children when they're young, getting people to lead a slightly different life, so you get a healthier lifestyle. It all ties in with a number of other things, that some of which I hope come back onto the agenda, like an increase in investment in sports facilities, because I just think that at the moment, I think these things are causing children an awful lot of problems. What I'm hoping is that the link up between preventative work and digital, when everybody starts to have their health records on their phone, and kids can have apps on their phone that look at that register what they're doing from a physical point of view, that they actually use these damn things to encourage kids to look at their health from a very, very early stage, and encourage the parents to do the same thing. So, as I say, there's the initial stuff that we can do, and there's stuff that, like I say, I think we can make a bigger case as we go forward for spending more money on health. If you get in on the ground floor with kids, you can bring down a lot of those costs all the way through the system. And so already what we're doing, I think, here is quite bold, but I think we've got to be more bold as time goes on, to try and get to grips with something that is either, if we don't tackle it now, is going to consume us at the end of the day, because medical science doesn't stop inventing things that keep us alive for longer, tackling more and more problems, more and more expensive drugs. Everybody wants them. You can rest assured when you come, my inbox is full of people saying, I want this, I want that, which is fine.
Yeah.
But people have to start taking ownership from an early stage, and we need to set the agenda for them and help them through that journey. So this is, if you like, step one in trying to get everybody thinking on those same lines.
Yeah, thank you. Are your colleagues able to give us any examples of specific
I could do so.
programmes?
We could have supported work in schools as a healthy environment, for example, and that might mean that the schools actually set their own priorities for how they would like to establish themselves as a healthier environment. Positive activities for teenagers would be another example. So that could cover a range of things. And then the whole issue about vulnerability in communities and individuals. And ensuring that we are very comprehensive in offering the support. So those would inevitably include some of the issues we mentioned earlier, where we're looking at people's housing and other factors that may influence their health.
Thank you.
Yes, I was just going to add that we're quite lucky in Jersey. We do have some really rich data. So we do run the Children and Young People Survey every 2 years, and we can see, what the groups of vulnerable families are right down at a school level and community level. So for quite a small investment, we could be looking at kind of how to target that, understanding a bit better about our more vulnerable groups. And to your point, also kind of tablet using the parishes and the local communities to step up what's actually needed in that community, which might look quite different in some ones from St Helier, for example.
Just to return to your point about the screening, investment in screening, is Jersey currently meeting current guidance and good practice on screening for cancer specifically? And if not, would this investment mean that we would be?
So I think we do have some challenges with our screening programmes which we need to address, and this funding would allow us to do that. Partly this is about the introduction of new screening programmes. So although it's not prescribed what any jurisdiction needs to offer, there are certain examples where we don't offer the screening programme to the full age range that might be offered, for example, in England. That said, there are variations between Wales, Scotland, England and Northern Ireland. Everybody varies a little bit, but I think now is the time for us to invest and ensure that we get our screening programmes up to the best level that they can be.
Are there any specific examples that are included in the plans for the 4 million that screening for what types of cancer?
Yes, so certainly extending the age range for the bowel cancer screening programme. So at the moment it's offered to those who are most at risk, but we'd like to extend that out a little bit more. Lung cancer screening we are fairly certain is going to be offered certainly in England, so that would be another example. And there are constant recommendations made about screening programmes, so we would anticipate more things will come in time.
Thank you.
Thank you. What data-driven methods are being used to identify areas of the population that need specific types of help? I think you mentioned the Children and Young People Survey. Perhaps you could start by telling us what have you noticed in terms of concerns around health?
So we completed a women's health JSNA which covered all ages, which actually showed some of the big challenges that we've got for half of our population, particularly around children being able to exercise and girls having enough of exercise. We also know that there's some challenges with women living longer but in poorer health. We have other data sets. Public Health have a number of health profiles that go across different populations that we can use too. We have GP records that we can access at a sort of anonymised level to show disease prevalence, and we can drill down to understand a bit more about that. So where we do have some quite good data to be able to undertake needs assessment and plan services better and really make sure that they're targeted more effectively at those more vulnerable populations, and also make sure they're more culturally sensitive.
Yeah, thank you. And some of those reports we've read with interest, and we noticed that there are health inequities across the island that are perhaps not that the needs of certain types of people in the population are just not being met. Would those needs be fully met with this 12 million, or would we need to invest even more to fully address health inequity in the island?
I think this is the 4 million is a start, and I think we need to really begin to think about how we're going to meet those inequalities. We will gain more knowledge as these programmes begin to be implemented, because we'll see who's coming and who isn't. But I think the other point that has been raised today is really relevant, is about the other assets, if I use that word, that are on the island, whether they're run through parishes or in other places, because we need to begin to coordinate those so that we actually have a community outreach. And part of that is about identifying people in the communities who are influential. And I think we have some more work to do there to meet people where they are. So that's going to be part of the future work, I think.
Thank you. And Minister, could you reflect for us on what you have learned from these various reports that point out inequities around gender, income level, disability, age? How have you reflected on that, and is it informing your work at the political level?
In amongst other things, yes, of course it is. It's an important part of what's happening. But I've tried to make the point all along that the more joined up we are, the more that we can look at these things in a meaningful way and bring about the change that's required right across the piece. So I think you can, hopefully you can see that everything is starting to be much more joined up.
Yeah.
And it's much easier then to apply, to take that data and do something with it. Yeah. Otherwise, you can look at it, you can see there's a problem, but you don't have the mechanism to actually make the changes all the way through the system if it's fragmented. So that's one of the reflections, I would say.
So addressing those health inequities is something that's important to you.
And I'd make another point, and while we're on prevention, it is worth mentioning that you haven't had a first meeting yet, but the Determinants of Good Health Ministerial Group, which is going to bring together health, ourselves, social security, housing, and children's minister, I think will be a very, very good forum for trying to, once this is underway and we're running, to try and to look at those things in the round from the top down sort of position.
Preempted my next question.
Oh, sorry.
I was
Right,
just
yeah,
going,
yeah,
no, that's
right,
great.
yeah.
I was just going to ask you about in terms of wider society, and again, this is very much at the political level. If we're talking about housing and you know, we see lots of units being built that are 1 bedroom or 2 bedroom, and I know that Andium are thinking about this because I've had some conversations with them. With this determinants of determinants of health group, could you raise the issue of housing, and how can we build housing that actually helps with health prevention and allows people to live more communally and to care for each other?
All the things that we're trying to address, and this particular group is very much in its initial stages. We're just drafting it up to try and get terms of reference and make sure it's properly formulated. And as I say, it is very, very early days, but I look at that going forward as being quite a key body of people looking at stuff, bring all the threads together, and that's where data capture and good data analysis is going to be quite crucial, because you can bring all the threads together from all those different departments and marry them up and see where you need to be. So it's a big piece of work, and it's going to take a while, but you've got to start somewhere, and we are starting. So
we'd love to hear some more information about what's on the first agenda of that group, and to
very
review
happy
any
to
minutes
report on
and
that. Yeah, I'm looking forward to that.
Thank you. Okay, so we've got the A&E questions on the hospital. Do you want to go to? Yes, okay. Okay, so I think we quite naturally will go on to the questions to A&E now, actually, and then we'll come back to the hospital questions. Are you happy to do the...
So going on to promoting the appropriate use of the emergency department. So bearing this in mind, will this system be managed within the current resources?
I think they have to be,
Yes.
I would say they have to be, yeah.
And so, as that's the case, what analysis, if any, has taken place to ensure the current resources required for management of this system is adequate?
I don't know that we've actually done any analysis to that effect. I think what we're trying to do is we've looked across the piece at the things that we think might be useful to drive good behaviour. And I'll make a comment, a sort of more political comment about the two things. We've got do not attend fees and A&E charges. The do not attend fees I don't really struggle with at all. I think that's fairly straightforward. The A&E charges, I know that that's a difficult one, and I know that we're going to have to be very, very careful with it. What we're looking for is permission to introduce them if required, but it's not a done deal that particular charge will be introduced. I think we've got to go through that in more detail, more carefully. What we don't want to do is introduce something that ends in an illness or a fatality because somebody's been put off going to hospital. By the same token, we want to drive good behaviour. We want to try and make the A&E department more efficient. So if somebody is sitting there that's going to go down with sepsis or something, they're not kept waiting for 4 hours because somebody's gone in with a graze and that they should have taken to the doctor. It's a very delicate balance, and I just want to assure you and assure the public that are listening in that before that one goes anywhere, we're going to be doing quite a lot more work to make sure that we sort the wheat from the chaff,
Yes.
so you get the right outcome without putting anybody at risk. I think that's important that everybody knows that. I mean, what we committed at an early stage, that when we were looking at things, we'd go public straight away, so people can say, why are you hiding everything? So we sort of wear our heart on our sleeve a little bit, in that we go public and say, look, we're looking at this, we're looking at that. I just hope people see that as being a positive way of keeping people informed. But there are certain things that we need to, certain areas where we need to provide people with reassurances, and that's one area where people can rest assured that we're not going to risk putting anybody at risk, if that makes sense.
Yeah, that's good to
So
hear.
it's work in progress, and if something happens, it'll happen at the right time, having given the thing due thought.
Yes, because we
Okay.
appreciate it's a really difficult step to take, but one that's probably quite
Delicate.
necessary.
It is.
But and you've probably already answered this, that you're still thinking about how we're going to. I was going to ask you, how will you determine what is an emergency?
Well,
Because that's what's on
that's
everyone's
what you've got
mind.
triage doctors for. But
Yes.
I mean, you might have to get to a point where they need particular training to as I say, it's work in progress. I don't want to determine how we do that, but I just want to let everybody know that it's work that's going on.
So you don't have a date in mind for when
there's
the
nothing-
public would be asked to
nothing
pay a
predetermined.
charge?
That'll if that comes about, it'll be ready when it's ready, not before. We're not sort of working to a fixed date.
Yeah, you haven't got any time.
Can I just
No.
jump in and follow
Yes.
up your question about who will determine what is an emergency? Minister, you said triage doctors. Will there be published criteria that states what is an emergency and what isn't, so people know?
Rather than me committing to anything, that sort of thing might well be where we end up going. But as I say, I'd rather we did the work and then come and discussed it, rather than me sort of, lash out. So we're going to do this or do that. I just want to give you the assurance that it's work that will be done. We'd be very open and transparent about what we do, how we do it, and when we do it.
So I appreciate that. Yes, it's an ongoing work, but maybe I should ask this so that
Fine.
it could be put in your work stream. That it's what measures are going to be put in place to safeguard the person, and assumed a triage nurse who'll be assessing and communicating the need to proceed with charging members of the public, because we realise that's
Fine.
front line and that's
We're
very
gonna just
difficult.
Take a note of your question and go away and look at that. So if you've got any reservations, the more you've got, the better. Put them on the table, because it helps us
I'm friends with an emergency nurse, and I think it's quite difficult for them. That if they're sort of saying that they have to turn away,
playing God,
And then, and one of them was, have you considered having extra security to be added? And if so, where would the funding for that be considered?
When you talk about extra security,
I know that quite often security is called into.
Oh right, that's
the
a sort of
emergency
slightly
department.
separate question.
Yeah,
isn't
but
it?
it's just
about
that
how
I
we
think
manage
it kind of
A&E.
follows on, because if a nurse or triage or the doctor is making and saying to somebody, actually, you need to pay, you're not an
That's a good
emergency,
point.
somebody might get quite.
If your charges outweigh what it would
Yes.
cost to have a security guard, you might think twice about it. But that's a point well made.
Thank you.
Okay.
Yeah, thank you.
Any follow-ups?
We're going to introduce a new policy, Minister, of charging people who don't attend for appointments. Would you like to say a few words about that?
Yeah, statistics that have been made available to me suggest that 1 in 10 appointments aren't kept. Most of those, nobody gets alerted to the fact. That causes delay. At the end of the day, instead of getting through X, you've got
One in 10, did you say?
1 in 10. I think I'm correct in saying that. Yeah, 1 in 10 appointments, people don't bother to turn up, and most often they don't bother to let anybody know, which is disruptive. I think it's discourteous, and I think what we'd like to do is try and make people. This is the thing, when everything's free, people don't tend to quite value it as much as they do, and I think if people knew. And as I say, when your appointments can be done on the phone, I accept that at the moment we've got a system where the appointments aren't quite as reliable as they might be. I mean, I have heard instances where somebody gets an appointment letter in the post that refers to an appointment time that was 2 weeks before the appointment was received. I mean, so that system isn't where it needs to be. This gentleman here is going to be looking at that. But once we've got a fail-safe system in place, I think it's and people they'll get reminders on their phone and so on, that we can be assured that they're not being messed about. Once we've got our house in order, then I think it's everybody's duty to get their house in order. At the moment, we're only looking at applying a charge to the second time it happens in any given year, which I think is generous, and that might have to be reviewed. So it's on the second occasion that it happens. And that charge will only be absolutely payable if they come in for treatment on the third occasion. They'll be billed, and if they don't pay them in the third time, come in and say, well, you have to pay your charge before you get the treatment. I think it's trying to get people to have some degree of ownership of the system, and encouraging people to feel that they have a the government has a responsibility to deliver a good health service. They've got a responsibility to help them to do that.
There's going to be some process, presumably, for allowing people to express an excuse for not attending.
Absolutely, there'll be criteria. They'll be given a certain period of time in which they can do it, and if they're exceptional, I mean, a number of people have written to me and said, "Well, if I'm in this position or this position, why should I be charged?" And I've said, "Well, if you've got an exceptional circumstance, you won't be. You know, if there's some sort of family mishap that happens, and people can explain that's something. Somebody who had hearing difficulties said they might have difficulties. So there will be exceptions, and we have to work on those to make sure that we've got the proper criteria and we're being fair and reasonable. But I don't personally think that it's wrong to encourage people to help to make the system more efficient. If you could reduce 10% of non-attendances to 2%, you're going to get that much more through your system. Your waiting lists are going to fall, and you're going to save some money, and we need to be doing that. So I think it's just about trying to introduce some gentle discipline.
When is this going to come in?
When it's ready. As I say, this is work that's going on to make sure the first thing we can't do it and we've got to get our house in order in terms of appointments. We've got to make sure that when people get their appointments, that they're 99% reliable, that we're not messing up. You can't have somebody being sent a fine when they've had a...
Right. So is it fair to say that you're trying to drive a culture change rather than bringing it in for financial reasons?
This isn't financially driven. It's behavioural change, it's culture change, as you say. Trying to engage with people more, make them a little bit more responsible for it, and feel more a part of the process themselves.
So, and just picking up on that point, that's the reason why in the government budget there's no income targets for these two fees, because we're not doing it to raise income. We're doing it to change behaviour.
Can you make a commitment that you won't introduce any charges until the systems are robust enough to support them? Because certainly I know from experience that those appointment systems do not work well. It's not easy to let the department know sometimes that you can't make an appointment, and the rescheduling also is sometimes problematic. So can you make that commitment?
Yes, I think, to be fair, I think when we issued our statement in the first instance, we did have a line that said that we wouldn't be introducing that till everybody's got their house in order. Before we start putting in charges, we need to make sure that our house is in order first. So that's a plain statement. Yeah, happy with that.
Thank you. Could you also reassure islanders who may have disabilities that would impact their ability to access or use these systems that those people won't be charged?
Yeah. Anywhere where there's a credible exception, fine.
And are there any accommodations, for example, assistance in accessing those systems? Is that something that you're considering as well?
That's in the sort of fine-tuning areas that we'd be needing to look at.
Okay, thank you.
Sometimes I don't know if we release too much information too quickly, because perhaps we invite controversy, but at least people know the direction of travel. People have got time to settle into that mode of thinking. So you're not sort of descending on people and saying we're making this change tomorrow. So people know what's coming through. It gives a chance for things to be discussed in the public domain.
And that's why we do these hearings.
No, which I think it is useful. I know it gets headlines, but some of the stuff hopefully will translate and people will get some clarity on it.
Sure. Yeah.
So the budget states that both fees will be introduced during 2026 after a period of advanced public communications. Is it just communication, or is there going to be consultation as well? Are you talking to the likes of unions about the impact on staff who may be, administering the charges? Are you going to go out to public consultation? What's the plan?
Can I add to that? So as well as unions,
if you can answer all the questions, I'll be much obliged.
to add to it, will you consult with charities, for example, that represent islanders with disabilities, so you know what kind of accommodations might be needed?
I think what we'll need to do is assess it, and we'll consult as we see appropriate. As I said, I don't want to spend money on a wholesale consultation process where it's unnecessary. I think what we need to be leave our team to look at it and say what do we sensibly need to do and what don't we need to do, so that we keep our costs down and make sure we consult if and when appropriate.
And then you'll tell people then what's happening. It will be a process of deciding and then communicating, as it says, not consulting.
There is a conflict there between, as Deputy Stevenson says, it says in the budget they will be introduced next year. You're saying, I think, not necessarily.
I would say that there's a likelihood that it'll be 2026. I mean, as I say, there's a slight difference between the two. The A&E charges will need to be certain that we can do that safely. If that had to be abandoned, it would be abandoned. I don't really want it to, because I think there's some good work that could be done. But that of the two, there's one that I think is wholly justifiable and can be done more simply. And there's one that's more contentious and has more risk associated with it, and we'll take a slightly different approach to that.
Okay, so to summarise, these charges aren't being introduced kind of 1st of January 2026,
no.
but
That's
you're
never been the
considering
intention.
it, having conversations with relevant people, and you will be giving information
We shall do our homework.
as you go.
Yeah.
Okay.
And do you need the permission of the Assembly via the budget to do it, or is it something that could still be done by the Minister?
The Minister needs the Assembly's permission to do it. He doesn't necessarily need the Assembly's permission via the budget, but he does need the Assembly's permission to do it as a result of an old proposition, I think back from 2010, when any new fee or charge needed Assembly permission to introduce.
And that's permission to do the work, or permission to just introduce it?
Permission to introduce.
Thank you.
So will you need to come back to the Assembly again after the budget?
If it goes through with the budget, it does give us permission to do that. But you've had the assurances that you need, and they've been very publicly made, so I don't think there's any difficulty there.
But that is asking states members to approve it without knowing any of the detail of it, whereas a future proposition would require more detail.
Effectively, but I think we work on the basis there has to be a degree of trust in allowing people to get on and do the job, particularly if they're being sort of open and transparent and making public commitments. It's really about the convenience of knowing that if we're going to put the resource into doing the work, we've got the backing to know that we're doing it, we're not wasting our time, if that makes sense. Because I think every penny we spend on doing any preparatory work, we're going to make sure that if we're doing preparatory work, it's going to prove useful.
Okay. I think we will move on to this section now, Deputy Stevenson.
Oh, sorry.
Yeah.
Okay, yes, on to men's health. What funding in the budget is allocated to men's health?
I've got to put my hands up here and say quite openly, I haven't made anywhere near as much progress on the men's health situation as I would have liked. I don't know that we've actually put aside, have we put aside, is there any money put aside specifically for men's health?
No, not specifically. There are a number of initiatives which would be beneficial to men particularly. So the work that we've done on suicide prevention, things of that nature, but we haven't got a specific earmarked fund for men's health. It's interesting as we go through the prevention proposals as well, because you know that the men have a lower life expectancy than women, and so there are quite a number of areas around prevention which again should benefit men. So heart disease particularly would be an area. That's where we are at the moment.
And in terms of the screening programmes, is there improvements to the prostate cancer screening programme?
So we're still waiting to see the best way to deliver that prostate cancer screening programme. I think it's one of the things that is likely to be recommended at some stage. There's quite a lot of health debate about how you best run that. The current proposals would mean a lot of men got false positive results, which may lead to more harm. But I think there are various ways to target that programme. The lung cancer screening programme will also benefit men particularly because of the legacy issues of smoking. But as I say, we don't have a dedicated funder.
I think it's fair to say, and I don't mind saying this, I think with the money that we've got, that we hopefully that we'll get from the 4 million, that will give us some money to start with. We can try and use our existing resources to get through year one. And whilst I'm on record, and I'm making a number of commitments today, I'll make a commitment that before we have our budget meeting, we'll have our first men's health meeting. So that pins me down to making sure that actually gets underway, because I'd like it to be functioning before we get into 2026. So I'll make that commitment that we get our first meeting together.
Is there a men's health strategy in place currently?
No, not to my knowledge.
No, so the work has been done in the past. So there is an older strategy which is now out of date, but a lot of the issues are known to us partly through the public health profiles and the work that was done previously. And I don't think we would find many surprises in there. The way that programmes are delivered is an issue more than the identifying the particular health areas of concern.
Okay, thank you. Do you know how long ago that was, or is that something you could come back to
From
us
memory, I think it was around 2012, something around that. I might be incorrect about that date, but it was around that time.
Thank you.
And that's achievable within your current budget and men's health strategy?
Well, I always have this issue about strategy. We can identify what needs to be done, and we can get on to do some stuff in the next 12 months. That's I put it more basically. Have a formal strategy.
Okay, thank you.
Moving to women's health, is there a figure for how much is being spent on women's health in the budget?
Is that something that Hazel might sort of be able to identify that?
We don't particularly categorise in that way from a budgetary perspective. As other colleagues have described, there will be sort of interventions and care packages which will be addressing women's health issues. I don't know if there's
It's covered within various existing budgets.
across a number of different areas, but
For example,
certainly from a monetary perspective, we don't tag it in that way.
It would be difficult to actually extract it from all of the figures and work out what's specifically for women's health, because there's sort of overlap, isn't there?
yes, I mean we're running out of time. I mean I think the women's health strategy has been talked about for quite a while. Is there a women's health strategy underway?
No, there's not a women's health strategy underway. The previous minister made a commitment to produce a women's health strategy. A decision was then made by the previous minister not to progress with the development of a women's health strategy, but that was not communicated before the changeover, before the changes to government. There is a women's health political advisory group. There is a intention that the women's health political advisory group will produce publish what's called a statement of intent, setting out what they think some of the key changes to women's health need to be in some of the key interventions. At the last meeting, the Women's Health Political Advisory Group, we spoke to them about 5 key areas of work that we thought should be progressed, which was some of it was work that was already under consideration. Some of it was findings that came through from the strategic needs analysis we did on women's health. The delivery of some of those 5 activities hinged on additional new monies through the prevention work, but in the cut from the 12 million to the 4 million haven't made it through.
Thank you. Yes, we will. So just on the women's health strategy, so Minister, I understand that something will be published at a statement of intent. And I just wanted to compare this area of health to one of the other areas where you seem to have a really comprehensive strategy in place with the digital health, and that spans several years. And that means that the next minister or next government will be able to follow that roadmap and make comprehensive services along that roadmap. Would you consider doing something similar for women's health so that could be part of your legacy?
I think about legacies, we just got a job to do, but it's a bit more complicated than that. I think when you break it down, if you compartmentalise everything, you end up with everybody being looked at specifically. If we look at women's health and men's health, and both of those subgroups work out what the priorities are, what needs to be done, you then feed that into the existing work that you're doing, and you look at where your preventative funds break down to help that particular category or that particular category, how your digital actually breaks down. So if you like, you've got the strands of funding across the piece, and what you're really doing is looking at those subgroups to feed in what needs to be done. So you could call it a strategy if you like, you can call it a job list. We can get tied up in the sort of semantics of it, but really it's about identifying what needs to be done, looking at the resources we've got and feeding that into the system to make sure that the work gets done.
It sounds like most of it is there, but I think what the
So
public
if
wants to
you
see
know,
is
perhaps
something published so
trouble
that
is
they
when
can...
when you put
Sorry,
when
Minister, I'll just finish. I think what the public would really like to see is something published with intent from you that will show where the direction of travel is, something really clear. Is that something you could consider doing?
I'd hope we've been fairly open about it, and if you want it slightly more formalised, I think we can do that on both the men's health and women's health front. Let's say, you know, if you want to put a label on it and call it a strategy, I mean, I think we're working to a strategy across the whole health piece, but we don't call it a strategy. It's it's become our business as usual. But I understand you want some clarity about what's intended for women's health, and you want some clarity about what's happening for men's health, and we'll try and formalise that process so that it fits in with the framework of what we're trying to do. Very happy to do that. That makes perfect sense.
Thank you. We only have 5 minutes left, and we've still got 2 sections, so let's try and get some questions in on the health insurance fund.
Minister, we've touched on this, I think, really at the beginning already, but the budget states at page 88 that the Minister is continuing to review the island's health and care costs with options for the future funding of our whole health and care system being developed in discussion with the Council of Ministers and so on. I mean, is it fair to say that the efforts of you and your department have really been directed towards ascertaining what is the real cost of the health system and what we need to operate a proper health system in Jersey, rather than where the money is going to come from at the moment?
You're probably right about the priorities, because I made the point when we spoke about this, or when we got under the heading deficit, is it's timing. Okay, at the moment, if we start to work out what we need and where the money is going to come from, we could lose 12 to 18 months. I think that we're in, I don't like to use the word crisis, but we're not where we need to be. We're not as organised as we should be. And if you want things to start changing for the better, you need some money now. That's why I'm trying to get some money in to start work on the 1st of January. And everybody here is geared up to start that work on the 1st of January. I have made it plain that we need to be starting to look at where money's going to come from in the future, how much we're going to need and where it's going to come from. It's a longer piece of work, and I didn't want, that has to be the secondary piece for me. Let's put out, if we've got some money sitting there at the moment that's being invested by someone else, we need to invest that in us. Let's get the work underway, and let's worry about how we start to fund that as we go forward.
I mean, it's not something which perhaps concerns you, but the
it does.
But the panel has been concerned for some time about the gradual diminution of the health insurance fund, running down to very low levels. And I must say that I was under the impression that work was being done 2 years ago, at least, on this particular topic. But that seems to have ground to a halt.
Well, I'd say in the first instance, health insurance, for those listening in, health insurance fund sits with Social Security Department and not with us, and that makes it a bit difficult. I mean, I don't know if you can elaborate a little bit more. It's not within our remit.
So we did start some work with the previous Council of Ministers. That work didn't progress. What we've done is we have picked up the work. We are working with our Treasury colleagues. We're working with our Social Security colleagues. We are, as you rightly say, at this point in time, the first task is to get a sense of the quantum of the size of money we need across the whole of the system, which we're working on. Alongside that, we have started work.
No options developed yet.
No, we've started. No options developed yet. We started some of the preliminary research work, and we will bring forward options.
It's accepted that it's running out and that needs to be addressed. So, and I think long-term care probably can need looking at as well. So there's an awful lot of things about health funding right across the piece that needs to be addressed. I know you've raised these issues, you're quite right, and they will be addressed. But as I say, unfortunately, so many hours in a day, you can only work on so much at any given point. And our focus has been on trying to get operationally more functional. But you make a good point.
Thank you, Minister.
Very briefly on the hospital, the budget continues essentially with the programme that was established last year. Can you just outline the reprofiling that's gone on to sort of slightly change those figures?
So I guess at the moment, are you happy for me?
Of course, yeah.
So at the moment we have a plan to build a hospital, don't we? And the days are going on and where that plan is becoming more and more certain. And obviously one of the key things that we need to do in order to build a hospital, an acute hospital at Overdale, is to have a main works delivery partner. And I think what we've always said in the programme is that we do have a programme of how it could be delivered, which is really important for financial modelling in order to come up with the forecasts that are in the government plan. However, it will very much be a function of the contractor who eventually will build the hospital, because they will have a methodology for building it. So I can say that the forecasting that's in there at the moment is on the basis of the modelling that we've done, obviously with experience of construction professionals to say how we might go about building a new hospital. Once our invitation to tender process is complete and we have a main works delivery partner, they will have a programme, and associated with that programme will be a cash flow, and then that would replace what's ever in the government plan. So the forecast at the moment is based on our modelling.
And in terms of what you can say publicly at the moment, where are you with that process?
So I'm really happy to say that we have received our invitation to tender stage 2A proposals from Main Works delivery partners. We have proposals from people very capable of building an acute hospital at Overdale. We're in the process of considering those and also launching the next stage of our tender process, which will be the invitation to tender stage 2B. That is in order to converge on a main works contract that will deliver best value for islanders in terms of the new facility. So we're right at the point between those 2 points in that kind of competitive process at the moment. And so hopefully we will have news in the coming weeks of the culmination of that process.
Okay, coming weeks.
Coming weeks.
And then there's just something we wanted to clear up in the budget. There is an allocation in 2029 of £10.5 million from the Central Reserve. What is that to do with?
So I am afraid I'm the person who spends the money and not the person who puts together the funding proposal, and I rely on my colleagues in Treasury to do that.
All right.
So
we can follow that up.
I can certainly clarify that separately,
I
or
can-
Hazel indeed,
so
of course.
I can, so in a similar way to the assisted dying, the money in this budget proposal in 2029 is held centrally. It hasn't been allocated to Health Department yet. So it's being held by Treasury centrally, and the detail is based on the outline business case that was put together for this project. So as Jessica was indicating, so this is a future estimate and around revenue costs that would be incurred once the hospital is built.
Are you confident that you're still within the £710 million envelope for the facilities?
Yes, for the whole of the phase 1 of the new healthcare facilities programme, we are still within.
Okay. I can keep going, but we're out of time.
We are over time, so I think we may have to follow up in writing. But thank you for everybody's answers. Minister, just finally, to close the hearing, could you just briefly summarise what this budget, if it's approved, would mean for the average islander?
I think the average islander would be able to know that their health service, that some of the misconceptions of the past have been recognised, and that now there's a very serious approach to getting health right on the island, and these set the foundations for that process to begin. As I say, I'll repeat, the ambition is to have a first-class health service ready to move into a first-class hospital. I've said all along, don't go and spend £600,000 or £700,000 building a hospital if you're going to move a third-rate or second-rate health system into it. And I'll also say publicly, I think there's a very good team come together, and I'm looking forward to the next 6 months, because that's all I've got. Anyway, thank you.
Thank you very much for your answers today, and all of your officers that have joined us. And thank you to the panel. I'll close the hearing.